Titled State of the Science on Behavioral Addictions. My name is Adam Leventhal, and I'm director of the USC Institute for Addiction Science. Before we get started, I just want to give a little background for those who may not be aware of our institute. We are a university-wide academic unit at the University of Southern California. And what we do is we promote collaborative, transdisciplinary research projects, community engagement programs, and education programs. And we really aim to come together to figure out ways to end the addiction epidemic and prevent new ones. And so as part of that, we have a community engagement and dissemination mission to educate folks about what's happening in terms of the state of science on key issues. And I'm very, very excited about today's event, right? So today, the impetus for this event is that, as many folks know out in the addiction science and practice community, we do talk a lot about psychoactive drugs, and rightly so. But what's often overlooked is non-substance related addictions and the growing scientific evidence that we have to understand and to treat these types of disorders. And what you're going to see today is a panel of some of the leading experts internationally on this topic who are going to give brief presentations about their particular domain of expertise. And so we have 5 speakers today, and I'll introduce them soon. And after each speaker gives their presentation, at the end, we will have a Q&A period. And so please, you are encouraged to put questions into the Zoom chat, and we will identify some of those questions to put forth at the Q&A at the end. So without further ado, I'd like to introduce our first speaker. It is my pleasure to introduce Dr. Steve Sussman, my colleague, who's literally written the book on the topic of behavioral addictions. He's a professor of population and public health sciences and psychology and social work at USC. He has more than 600 publications. He's developed evidence-based prevention programs for tobacco use, drug use, smoking cessation for youth. He's a fellow of several organizations, and he's currently editor of Evaluation and the Health Professions. As I mentioned, his newest text from back in 2017 on substance and behavioral addictions, concepts, causes, and cures really is one of the mainstays in this area. And he really just maintains a strong interest in addiction science broadly. So I'm very excited to introduce Dr. Steve Sussman.
Okay. Thanks, Adam. Yeah, there's a lot of folks that have entered into the arena of behavioral addictions. There's a journal for that purpose in an organization, the International Society for the Study of Behavioral Addictions, and so for those of you who are interested in it, there's plenty of room for kind of more involvement. There's a lot of folks doing some very good work. But anyway, so what I'm going to do in the next 12 minutes is to kind of define the addictions and how they can apply to behaviors as well as substances, and then give a little bit of background on potential prevalence and co-occurrence of the addictions, and it kind of introduces what the speakers that will come after me in that sense. Next slide, please. Hello. Hi, Vicky, what's
I am working on it. One sec. Sorry.
Sorry, too many screens going.
Okay.
Yeah, you're clicking the.
Okay, so well, to kind of introduce things, and the slides will come up. One is when we're talking about addiction, where there's kind of two main models that people have applied to behaviors, but to basically one kind of model that I've been utilizing is the 5-component model, and it summarizes or makes more concise some of the other models. Basically, what we're talking about is a dysregulation of appetitive motivation systems, neurobiological appetitive motivation systems. It involves misdirecting inputs to fulfillment of appetitive motives through either intake of substances that reliably impact neurotransmission or engagement in behaviors that reliably impact neurotransmission. That neurotransmission will become reliant on those behaviors. Next slide, please. So when we're talking about appetitive motivation, we're talking about a whole series of needs that we all kind of carry around with us. Certainly hunger, thirst, sleep, but also to love and be loved, to be part of a group, to be either to have a kind of a place in the sun within the group, or to be part of that, submit to a social order for protection. All these are kind of appetitive motives that we can that behaviors or substances can apply to give us the feeling as if we are fulfilling these motives. Next slide, please. So there are 5 underlying constituents of addiction. Then, given this kind of perspective where we have, the appetitive needs, we can obtain effects from these by engaging in these behaviors or engulfing, substances, where we will then obtain a sense of temporary satiation, period of feeling self-sufficient, okay, incentivized, subjectively experienced as improvement in affect, or improvement in arousal, or improvement in cognition. Which some people in recovery will call, if they want to decrease cognition, for example, they call it achieving oblivion. The third component is preoccupation, where after engagement in that behavior over a period of time, people will think about it. And that's the terms tolerance, withdrawal, craving, all kind of focuses in on preoccupation. Loss of control is difficulty knowing when we'll begin the addictive behavior, or when we do begin it, how long that it'll last for before it stops. That involves terms like when we throw in impulsiveness, or we throw in, lack of control, relapse. Finally, it's undesired negative consequences result, and there's a whole variety of negative consequences and injuries to one's quality of life. When we're thinking, about the difference between passions and addictions, if Mark Griffiths said, if it's not a problem, it's not a problem. But, if it is a problem, it's likely to be not a passion, but an addiction. Next slide, please. So to give you an example, and of course, Andrew will talk much more about this, it's just looking at the criteria, the DSM-5 criteria for gambling disorder. You can see that the areas of the appetitive motive here that the DSM-5 utilizes. We could see preoccupation there. We could see a loss of control in there. We could see negative consequences, undesired consequences in there. So you can see kind of built into this kind of listing definition, which has its own difficulties, but listing definition of gambling as an addiction. It is, you could kind of see it here. There's the 5 components definition. It's kind of built in a sense. Next slide, please. So, you can differentiate addictions from compulsions. If you have a narrow definition of compulsion, it's basically simple repetitive activity like tying your shoes or washing your hands a million times, not pleasurable, ego dystonic. People will sometimes also use impulse control disorder. Gambling, before it was considered an addiction, the DSM-5 was considered an impulse control disorder, which just says, oh, geez, we have a lack of research to place the behaviors being considered an addiction. So lived experience as an addiction is not considered sufficient. And that's kind of the state of the science right now, or perspectives that experts have regarding the addictions. Next slide, please. So in terms of thinking about prevalence and of the addictions in considering substance and behavioral addictions, one study that I was involved with years ago is looking at doing a systematic review of the literature on 11 what we call focal addictions, focused on studies with at least 500 subjects in them, adult subjects, supplemented, unfortunately, we had to with smaller scale studies looking at prevalence in the US and some focus on co-occurring addictions, that is, 2 or more addictions. Next slide. Here are the 11 addictions. So for lack of time, I won't go through them, but you can see we have 3 substance addictions and we've got 8 behavioral addictions here that are represented. Next slide, please. And so we went through various search engines, and actually a graduate student at the time, Nadra Leisha, was the one who I kind of directed her to do a couple thousand searches to basically have an exhaustive look at the literature at that time. Next slide, please. We found 83 studies. These were kind of the primary addictions that were looked at, and the number of studies that were able to, uncover each of these addictions. You can see some of the studies that were very, very little work done. People even chuckle when you mention the word like love addiction. But okay, next study, please. So after a variety of assumptions, we came up with this kind of list, which indicates kind of prevalence in the first column, prevalence of these 11 focal addictions. And then you could see it's kind of co-occurrence. If a person at that time was addicted to cigarettes, now would be nicotine products in general, it would be vaping or cigarettes, or still would probably add up in terms of nicotine, would add to about 15% to the person. But at that time, if you're addicted to cigarettes, and there's a 50% likelihood you also had a problem with alcohol. If you're into gambling, there's a 50% chance that you'd be involved in problematic cigarette smoking. So you can kind of see how that table was constructed. Note that eating or food addiction was 2% at the time. When Dr. Gerhardt, when Ashley does her talk, you'll see that prevalence is actually probably much higher. But generally, these prevalence estimates and co-occurrence have been replicated in numerous studies. So in general, it tends to work out, but it may have indeed underestimated food addiction. Next slide, please. So what does it say when given different assumptions? The prevalence of one of these 11 addictions, a problematic level of involvement. So that not just these behaviors, but behavioral addictions or substance addictions. The prevalence of them in a 12-month period is 46%, and the percentage that reports 2 or more of these addictions is 23%. Next slide, please. So, of course, there was a paucity of data on prevalence of co-occurrence. You can kind of see that. There were relatively few studies that examined multiple addictions. Also, we did not account for substitute addictions. We're looking at co-occurring addictions. So some of the estimates may have been underestimates in terms of thinking about 2 or more addictions over time. So here's where you can see Dr. Sinclair's work. Next slide, please. Here she'll be our last speaker. So the conclusion is that manipulation of neurobiological circuitry to obtain a more comfortable subjective state occurs, that a large minority of the world's population suffers from an addictive process at any point in time, including everyone on this who's on our presentation right now, and that in a sense what we're dealing with is a natural state of affairs, this kind of them out there versus an aspect of being immersed in an addictive kind of modern lifestyle is what basically the conclusion of the study is. Could you click on one more? So Marx talks about life is a series of addictions, and without them we die, which is kind of curious. Next slide, please. Then I want to mention a two-part empirical study. We developed kind of like a multi-response matrix to assess these 11 addictions, and did interviews of over 700 former alternative high school youth in Southern California. They were an average of 20 years of age, a pretty heterogeneous sample. Next slide, please. Looking at these groups, and you can see that there were two classes doing latent class analysis. There were about 2/3 of the sample tended to be very low on all of these 11 addictions, but then 1/3 of the sample seemed to be very, very high on all these addictions, particularly the highest on kind of love and sex addiction. So note when Dr. Rory Reed gives his presentation. But we also want to know what happens, how stable are these addictions over time. So we went ahead and we did a follow-up study 1 year later. We were able to retain about 550 of these subjects. Next slide, please. And we found that the addiction class and the non-addiction class, doing latent transition analysis, that these were stable. I mean, 90%, 89, 90% remained in the addiction class. 90% remained in the non-addiction class. They weren't crossing over between addiction and non-addiction classes. There was some apparent addiction switching within the addiction class. People who were addicted to nicotine tended to stay addicted to nicotine. Very high stability, very nasty addiction. Hard drug use is pretty high. A little bit lower, but still moderate for sex, work, exercise, internet, love, eating, and or food and shopping. Relatively low for alcohol and gambling. Gambling might have been very low just because prevalence is only was 2% with gambling. It tends to be lower. That's, of course, we can get third-party payments because the relative prevalence of gambling addiction is pretty low in the US. It won't cost insurance companies that much. Next slide, please. That leads to kind of a theoretical model, which says, maybe for folks who are vulnerable in terms of fulfilling their repetitive needs, what happens in terms of associational learning and associated memory for alternative behaviors, and it can kind of feed into lifestyle factors that also then, basically we develop kind of addictive or non-addictive behavior, really feeds into lifestyle, feeds back, into associative learning, and then how you can kind of maintain in a kind of an addictive, lifestyle. Next slide, please. And and finally, I kind of added this. We live in a modern world where there's plenty of pulls to engage in addicting behaviors. You can see the particular, burger places where cars will line up. Everyone wants to feed their food addiction, and then there's also a lot of pushes. There's a lot of stresses in a fast-paced technological world. So you've got these pushes and we've got these pulls that can kind of lead us into ending up falling victim to various addictions, which then others will now kind of talk about. Next slide, please. That's contact information. Feel free, if you have any questions, contact me, and that's my presentation. Thank you.
Thank you so much, Steve. Great presentation to set the stage for the rest. And so it is now my pleasure to introduce Dr. Andrew Kim. Dr. Kim is an assistant professor in the Department of Psychology at the University of Calgary. He's also an adjunct scientist at the University of Ottawa Institute of Mental Health Research at the Royal. He is chair of the Canadian Psychological Association's Addiction Psychology section. His research expertise focuses on transdiagnostic mechanisms within behavioral addictions, and including gambling disorder. And he also has clinical expertise in providing evidence-based care for people with co-occurring addictions and mental health difficulties. Please take it away, Dr. Kim.
Thank you so much. Yeah, I know my slide says Toronto Metropolitan University, and just because I recently switched institution to the University of Calgary. But if you want to get in contact with me, my email that's noted on the left still actually works. So I'm really excited to be here and to provide a brief overview of gambling disorder. And what I really want to highlight here are some of the unique aspects of gambling disorder compared to substance use and other behavioral addictions, as well as current directions and recent developments in the field. So next slide, please. Okay, so just a brief outline. Start with a quick definition of what is gambling, give an overview, the latest data on what the prevalence of gambling and problem gambling or gambling addiction are. When does gambling become an addiction? Talk about risk factors here, highlighting some of the unique risk factors of gambling and the current directions in gambling research. Next slide. All right, so here is a pretty standard definition of gambling. And so gambling is defined as any activity or practice of placing a wager, which is typically money, on uncertain outcomes with the intent or expectation of gaining a larger reward. Now, I put here typically money because it doesn't always have to be money. It could be things like items, or when it comes to recent developments, perhaps even virtual items, and we'll get into a bit of the definition of that. And with this uncertain outcome, in terms of gambling, there are distinctions between activities that may be purely luck-based, such as slot machines, or that may contain some element of skill, such as poker or sports gambling. But regardless, there is this inherent aspect of randomness and uncertainty. And so gambling is defined as any activity that has this uncertainty or random component. Next slide. And when we look at the prevalence of gambling, and so like most other addictive behaviors, a lot of people engage in them, but a small proportion may develop a problem. And so according to recent prevalence rates, data analysis, and metas, the worldwide prevalence of gambling activities, majority of adults, 70 to 80%, report having gambling in the past year, but only a small minority, roughly around 1 to 2%, will experience a gambling disorder or gambling addiction. And it does vary by jurisdictions. So as you can see, the rates of gambling are fairly high in Western countries, but it may be a little bit lower in other jurisdictions and other countries. And that's because in certain countries, such as, say, South Korea, gambling is largely prohibited. There's only one casino in Korea where South Korean citizens can actually gamble. Now, if you've been to Korea and say, you know what, I've seen casinos and they're for tourists and foreigners, but if you have a South Korean passport, you will not be allowed in. And at the bottom, you can see that at-risk gambling is about 2.4%, so that's not meeting diagnostic threshold, but maybe experiencing some problems, and problem gambling is at 1.3. Next slide. So Dr. Sussman talked about the criteria for gambling disorder. I'm not going to go over these, but what I did want to highlight is some of the unique aspects of gambling disorder. And just to highlight here, number 6, chasing losses. So again, that's a bit of a unique aspect. And if you compare the substance use disorders, the alcohol use disorder to gambling, you'll notice there are a lot of similarities, but there are some differences. And in case of gambling, money is one of the big ones. Next slide. And so in terms of who's at risk, and again, a lot of the etiological risk factors and maintenance risk factors of gambling disorder is fairly similar to substance use disorders and other addictive behaviors. And that's one of the many reasons that gambling disorder was moved from the impulse and control disorders section to substance use and related addictive disorder section, because there are a lot of similarities in terms of risk, etiological risk factors, clinical course, and evidence-based treatments. So things like genetic vulnerability, there's a family history of gambling. So if you have a first-degree relative, you're more likely to develop a gambling disorder. Not to say you will, but there's a higher risk. Psychological vulnerability, early life experiences, childhood trauma is a fairly big, robust risk factor of gambling, as it is many other addictions and mental health. Social determinants of health, so lack of housing, food insecurity, financial insecurity is also a risk factor for gambling. One of the unique aspects in terms of gambling is that if it's financial insecurity, gambling is one of the few legal-ish activities that we have in society where you could actually make money fairly quickly. But of course, in the long run, you're most likely to lose than you are to win, but that option is there. Then you have this behavior model where there's exposure to gambling, and then which may lead to problem gambling. Next slide. So here are some unique risk factors of gambling disorder I want to highlight. So overall, gambling disorder shares a lot of similarities in terms of risk, clinical factors, as I mentioned, to other substance use disorders and other behavioral addictions. But here are some unique aspects. So in terms of gambling, in terms of the structural characteristics of gambling activities, there are two broad domains. So we can have discrete. So these are events that happen not fairly often. So for example, lottery tickets are a really good example of a discrete form of gambling. You buy a lottery ticket and then you wait maybe a couple of days to see if you won. Versus continuous. And these are when the outcomes of the wager are known rapidly. So think a slot machine, right? You can spin a reel every 3-4 seconds. So that's a continuous form of gambling. You're always wagering, you see the outcome, and it really enhances the rate of reinforcement. And as I touched upon briefly, luck versus skill. So there are certain gambling activities that are purely luck-based, slot machines, roulette being one. And there are others that actually do have an element of skill, things like poker, blackjack, and sports betting. Cognitive distortions, while are present in substance use disorders and other behavior addictions, it's really heavily implicated in gambling. So gambler's fallacy is when people think that previous outcomes will influence a future outcome. So you flip a coin, it comes up heads 9 times, and so someone who may have a gambling disorder will think it has to come up heads or tails because it came up 9 times heads, so the next one has to be tails, when we know that the previous 9 outcomes is not going to influence what this outcome would be. And in working with people with gambling disorder, I find that cognitive distortions are very difficult to shift. Right? You can talk to them about odds, how gambling works, how slot machines works, and they'll say, yeah, but I know which machines will pay out. Like I have a system. So these cognitive distortions are really implicated in gambling disorder. And the other unique risk factors is financial motives. And one of a etiological risk factor of gambling that's sort of unique is a big win early on. So if you're starting to gamble early, and then you experience a jackpot, that can be a risk factor of developing a gambling problem. As well as people who are more motivated to gamble for money, they're also more at risk of gambling as well. Next slide. And so like other addictions, the 2 evidence-based treatments for gambling that I just want to highlight are motivational interviewing and cognitive behavioral therapy. So if you're interested, these are 2 meta-analyses that are relatively recent that will summarize the state of evidence in regards to evidence-based treatments for gambling. Next slide. Okay, so one of the aspects that I think is really interesting and unique to gambling that I want to highlight is the role of technology. And so gambling and technology are very intertwined with each other. Here is a picture of one of the older versions of slot machines. So you have simple 3 bars, 1 reel, and you have that little handle to the right. And these used to be called one-arm bandits because slot machines, the more you play, the more you're going to lose. So that's a picture of what were common slot machines maybe 10, 20, 30 years back in the day. And now here is a picture of a current slot machine. Next slide, please. And so they're called electronic gaming machines because they're very high tech. And so instead of 1 reel, you can have upwards of 5 by 5, so 25. And you can bet on multiple lines. There's all these fancy graphics. It makes all these sounds. It's very exciting. And one of the other recent developments is that some slot machines have a skill element. That sounds funny, but these bonus rounds are more like video games and arcades, where the better you do and the more skill you have, you can win more money or win more free spins. And so you can see how gambling technology, because of technology, gambling can always evolve and there could be newer forms. Next slide. And one of the current debates, or one of the current hot topics in gambling research, is sports betting, in part because there's legislative changes both in the States and in Canada, but also technology with the development of smartphones and other aspects that have really transformed of how people engage in sports betting. Now, I do have a clip from Jason Kelsey and Travis Kelsey. but I won't show it, but it just essentially talks about how common gambling is, even among NFL players, and why that might be the case. And that's partly because of the increased accessibility and availability of sports betting. So we can just skip this for now. If anyone's interested, you can find it on their channel. And so one way that technology has shaped sports betting is there's been newer forms. So before all these legislative changes, at least in Canada, and I'd say most parts of US, you had to bet on multiple outcomes, right? So you have to bet at least whether team A would beat team B and team C would beat team D. But now you can actually bet on a single event. You can wager on one outcome. Before that was not allowed, but now you can just say, I'm going to bet $20 whether team A beats team B. What that has done is allow for the event of in-play betting. So you can place any bets as much as you want as a game is ongoing on who's going to win, what's the final score, who's going to score the next touchdown. And so it's turned sports betting from this discrete form, like a lottery ticket, where you pick your team and you watch and you wait till it ends, to more like a slot machine where you can make hundreds of bets in a given game. And in the next slide, here will be a quick example of this. Now, unfortunate picture with the Jays just being eliminated a couple of days ago, but a baseball game has roughly 200 pitches, takes about 2.5 hours to play. What that means is that you can make a bet every 35 seconds in a baseball game. Within a 2.5 hour period, you can place 200 bets. And that has really transformed the risk potential of sports betting. Next slide. And so just to highlight that the structural characteristics of in-play betting and sports betting have made this activity a continuous form. It was a discrete form, which has a lower risk potential, but now it's a continuous form with a higher risk potential similar to slot machines. Next slide. And so some of the research that we've done in my lab is looking at, okay, so if in-play betting and sports betting is transitioning to this more continuous form, and we know that slot machines are the most harmful form of gambling, partly because you can make a bet every 3-4 seconds, is in-play sports betting also associated with greater gambling harms and increased problem gambling? And we've conducted several studies in the lab. So one of the studies, we recruited 920 adults who engaged in different types of sports betting, so the more traditional, single event and in-play. And what we found was that in-play sports betting was associated with greater gambling harms, greater problem gambling, and psychological vulnerabilities compared to single event and the more traditional form. Importantly, though, single event did not differ from parlay. So it's not just betting on one outcome that seems to be associated with problem gambling. It's really that being able to bet continuously. In a follow-up study with EMA, looking at the contextual antecedents or why people may engage in in-play betting and what may be associated with more harms, we found that simultaneously using alcohol and cannabis, being in the game, so really being involved in sports, and coping motives, so gambling to cope with negative affect, and problem gambling severity were associated with greater in-play betting, money spent, as well as harms. And in a study that's currently under review, Sophie Coelho, who is here, we looked at potential regulation strategies and found that setting financial limits reduced gambling-related harms with in-play, but not time limits. And that makes sense, right? Again, if you set a time limit, 2.5 hours, 200 bets, you can do quite a bit of damage. Next slide. So the other aspect that I will cover, if you have any questions, I know I'm running out of time, is loot boxes. Essentially, if you go to the next slide, they're essentially virtual items that are found in video games, and there's lots of debates whether these are gambling or these are gaming, and it really depends on your definition of what is money's worth. And there's some research saying it is linked, but I'll just end with that. We need more research longitudinally, as well as cross-cultural studies, given gambling as a global phenomenon. So if you have any questions about any of sports betting, loot boxes, gambling, feel free to contact me, and I'd be happy to answer any questions. Thank you very much.
Thank you, Andrew. That was fascinating, but also disturbing a little bit with the kid-friendly gambling. It's my pleasure to announce our next speaker, Dr. Roy Reed. He is a professor of psychiatry and a research psychologist in Department of Psychiatry and Biobehavioral Sciences and the Neuropsychiatric Institute at UCLA. His work is a scientist practitioner model base where he aims to provide empirically supported treatments to clinical populations struggling with various mental health issues, including substance use and behavioral addictions. He also has a line of research in some of the neurobiological mechanisms of addiction and some really kind of interesting work that he's leading in. I want to make sure to get the acronym right. I think it's compulsive buying shopping disorder. So very, very fascinating and really pleased to have Dr. Rory Reed. Thanks, Rory. Take it away.
Thank you. Thanks for putting this together and coordinating it, and for all of those that are in attendance that are interested in these topics. Sex addiction always raises eyebrows, as you can imagine, and gets interesting responses from various people, from the critics to the naysayers and to people that are really struggling with this issue and seeking help. Next slide. The field at large over the past decade or two has really struggled in terms of, like, what do we even call this non-paraphilic dysregulated sexual behavior? And there have been lots of different names that have been proposed and controversial. And these are amongst a number of them. With the advent of the ICD-11, we did settle on compulsive sexual behavior disorder. Although, as Dr. Sussman mentioned earlier, a lot of times things end up as impulse control disorders because there just isn't sufficient research to characterize or classify them as an addictive disorder. Next slide. So I'm not going to go into a lot about the models. Dr. Sussman kind of addressed that. And, when people debate in the academic literature about the various nuances of whether or not this is an addictive disorder, they're not negating, and I'm thinking of a couple of people that have been animate about their disdain for the notion of sex addiction as a construct. They're really debating the best model to describe the phenomenon, not debating the fact that people struggle with this dysregulated sexual behavior. There is some overlap on some of these philosophical and models, and that's theoretical models, and that's what, again, kind of makes things even more cloudy. Next slide. So we did a field trial on hypersexual disorder and published our findings, and we did find, and this was proposed for the DSM-5, we did find that there was evidence to support the validity and reliability of the proposed criteria for hypersexual disorder. However, ultimately, even though the sexual and gender identity disorders work group recommended that it should be included, ultimately it was excluded from the DSM-5. Next slide. And so the ICD now put out, they put out their page for public debate and discourse on this, and looked at the research and the science, and ultimately did include it under the impulse control disorder section. And again, it's kind of what Dr. Sussman was saying. Is this because this is the best place for it, or is it just because we didn't have enough research to substantiate this as an addictive disorder? I would argue that if you would ask me just to speculate, I imagine that compulsive sexual behavior disorder will take the same trajectory as gambling disorder. It was once classified as an impulse control disorder, and research continued to accrue, and ultimately it was classified in the section for addictive disorders. I imagine that compulsive sexual behavior disorder will take that same trajectory as the research continues to grow. Next slide. So again, the criteria for this are similar to those that have been outlined for other addictive disorders, interestingly enough, and that is that there is this idea of, the lack of control, multiple unsuccessful attempts to try to abandon the behavior, negative consequences that are accrued in interference with people's lives. And also with the DSM-5, one of the things we noticed is that there were some disorders like ADHD, for example, where we used to use language like it had to impair people in their activities of daily living. And some of the nuances of the DSM-5 were that we saw the introduction of language that talked about interference in various symptoms that could interfere, but the totality of the symptoms caused impairment. And so, you know, with this, we see some of those same things kind of influencing this criteria. Next slide. So again, this idea that people continue to engage in the behavior despite these negative consequences. But one of the little nuances here was the persistence in the behavior, even though someone derives little satisfaction from it. It's kind of like the person who struggles with cocaine addiction. They love cocaine, they hate cocaine. It's that love-hate relationship. And then obviously we see a pattern where it's persisting for you know, a period of time that's substantiated is not just some bad choices when someone's in Las Vegas for the weekend, but no, this is an ongoing pattern over time. Next slide. So again, the marked distress. And one of the things that the ICD was very particular about was noting that, listen, this can't be related to moral judgments, you know, that, and it can't be as a result of like, you know, someone's in a manic phase of bipolar and they engage in, you know, sexual behavior. Someone's high on meth and they engage in risky sexual behavior or problematic sexual behavior. It has to be kind of independent of those sorts of things. So that was important. And again, part of this was because we didn't want people, religious groups, pathologizing people's right to sexuality or, you know, manifestations of what might be a more parsimonious explanation, like, you know, someone's having manic phase of bipolar and they engage in risky sexual behavior, and then all of a sudden they're being characterized as having sex addiction. The one thing I will say, though, is that, you know, there was some debate for DSM-5. I've published some papers on this about the controversy, but this idea that like, well, we don't want sex offenders using sex addiction as an excuse to justify or rationalize, you know, pedophilic kinds of behavior. And I rejoined with the argument and I said, look, this is like saying, you know, all right, we can't diagnose someone with anxiety if they have depression. Right? We can only choose one. And that's silly. The, you know, 40% of people who have depression also have anxiety. Well, it's also true that someone can have a paraphilic disorder and also have a sex addiction or a compulsive sexual behavior. We're not saying that the paraphilic manifestation of paraphilic behavior is an addiction per se. We're saying they can have both disorders concurrently. So that was our way to, and again, I published a paper on that if anybody's interested. Next slide. So we did develop recently a scale, and again, there have been lots of scales, right, that have been developed, over 21 scales that have been developed, including one of my own, the hypersexual behavior inventory, to kind of capture the notion of sex addiction or hypersexual behavior. But I really, what I was trying to avoid, I said, okay, now that we've got this kind of canonized as compulsive sexual behavior disorder, can we just develop one instrument and get all the people, the experts in the field, let's get all together and let's just create one measure and not have 21 different measures that, you know, so it kind of just messes up. And I really wanted to kind of create that so we could have a more parsimonious approach to research and all the clinical trials and everything else that I knew would emerge. So we actually did end up developing the compulsive sexual behavior disorder diagnostic inventory. And you can see there's a lot of the Eli Coleman, myself, and others on there to really kind of, you know, discourage other people from developing. Not that we're trying to squelch innovative research, but we really said, look, this measure, let's just stick with one measure and whatnot. So next slide. So the risk factors are common and similar to other disorders. You know, these sorts of things can be concurrent and also indicate a more difficult trajectory in terms of recovery. So let's just go ahead and jump through these. People, I'm not going to read the slides, people can read them, but these are issues. We also see clinical levels of impulsivity, in about half of these patients. And again, these are risk factors that are associated with a lot of the clinical presentations that we see. So clinically, if someone comes in the door for compulsive sexual behavior, we know we're going to be treating other issues. This is a study that we did looking at impulsivity, because everybody says, well, everybody's impulsive that has a sex addiction. That's not true. And it's actually not true for people with gambling. It's not true for people with meth abuse, right? We took a look at these 3 different addictive kinds of patterns and found that we looked at clinical levels of impulsivity, and it was only true for about half in each group. So to say that they're all impulsive or everybody has this is not accurate. Next slide. Again, just a slide indicating the prevalence of concurrent. And then again, that's fine. You can skip the manifestations. Solo sex with pornography in the DSM-5 field trial appears to be the most prevalent that we see, but those are the other ones as well. Next slide. Treatments, let's just jump through this. So again, the research on clinical trials and outcome studies are still emerging, and yet those are the ones that seem to be developing some momentum for evidence-based approaches, and the others have still are under investigation. Next slide. Some of the pharmacological, this paper was just published recently, suggests things like naltrexone and SSRIs may be effective in reducing compulsive sexual behavior. That's kind of the general consensus right now in the state of in the field. Next slide. Also, I think we need to address other issues. This is a study we published a while back, just saying, look, we need to look at ways to reduce shame. Shame is a very common problem with compulsive sexual behavior. And this was a model that we promoted that said, look, if we can help people cultivate self-compassion through mindfulness and other kinds of behavioral therapies to attenuate the shame, then that's going to reduce hypersexuality. We found evidence for that. Next slide. So conclusion, it's currently an impulse control disorder. We've got a psychometrically validated instrument to study this. And, the research is a lot of the research that was done on sex addiction and hypersexual behavior. People are just redoing those same studies with compulsive sexual behavior disorder as a new title, even though the criteria for hypersexual behavior or compulsive sexual behavior and sex addiction, they're all kind of talking about the similar thing, very little difference in the symptomology. But now all of a sudden what we're seeing is just studies being repeated, but we're calling it compulsive sexual behavior. So we're going to go those rounds. I didn't get a chance to talk about neuroimaging because that's a whole presentation in of itself. And the field is wide open for many new and novel investigations. And it's an exciting field to be a part of as we continue to study this. And certainly with the hope of developing really effective treatments to reduce the suffering and the pain that people that are afflicted with these disorders are experiencing. Thank you.
Thank you, Dr. Reed, for that. Yeah, excellent presentation. So it is now my pleasure to introduce Dr. Ashley Gerhardt, who's a professor of psychology at the University of Michigan. She's a clinical psychologist who currently investigates the role of reward dysfunctioning in terms of eating-related problems across the lifespan. She uses multi-method approaches, and she is currently the director of the Food Addiction Science and Treatment Laboratory at Michigan, and literally has her own fast food restaurant lab, which is really cool. And many of you know that she is the original developer of the Yale Food Addiction Scale, which has been cited over 1,000 times at this point. So really excited to have Dr. Gerhardt talk to us about the latest research in this area. Take it away, Ashley.
Hi, everyone. Thank you so much for having me today. I'm so thrilled to be here. And I'm learning a ton. I just feel like my brain is full of lots of new, fascinating information. And I'm happy to speak with you all today about my research area, which is trying to understand the role of addiction, specifically in the excessive intake of really highly processed food. And when I talk about highly processed food, I mean foods that have unnaturally high levels of refined carbohydrates like sugar or added fat. So here's a little picture from our local ice cream store in Ann Arbor. Attention chocoholics, come get your chocolate ice cream. Next slide, please. So when I first started to do this work in the early 2000s, we noticed there really wasn't a measurement tool out there to try and conceptualize the role of addiction and excessive food intake. People were kind of asked to self-identify as a carb craver or a chocoholic, but nothing kind of standardized. And so in 2009, my colleagues Will Corbin and Kelly Brownell and I published the original Yale Food Addiction Scale. It's now in its second version. And it really just takes the DSM criteria for substance use disorders and applies it as if that substance is a highly processed food. So the most recent version assesses loss of control, cravings, and ability to cut down despite a desire to do so, continued use despite negative consequences, tolerance, and withdrawal. And the current version, which is freely available for use, is a 35-item measure. And when you calculate it, it gives you both a symptom count ranging from 0 to 11 of how many symptoms have been clinically significantly met, as well as a diagnostic threshold of whether people have 2 or more symptoms in the last 12 months and meet for impairment or distress. And in this field, emerging field of food addiction, I would say that this scale has been pretty much the main tool used. I thought Dr. Reed's presentation was really interesting to think about fields where there's a number of different scales that are being used and how we converge across that data. And here, the YFAS has kind of been the predominant tool that's been used consistently across the research. You can, next slide, please. I wanted to give you a little bit of a sense of the lived experience that we see with individuals coming into our lab who meet the food addiction criteria. And this is someone who met for severe food addiction criteria, so 6 or more symptoms plus impairment or distress, and said, I can't even be in the same vicinity as Krispy Kreme or any type of donuts because I will finish a dozen all by myself. And I'm a type 2 diabetic, so that could kill me. And I know that. And I know that I shouldn't be eating all those. I shouldn't be eating one, let alone a whole dozen. But for some reason, I just can't stop eating them. And so when I hear something like this, I hear the compulsivity. I hear that people know there's negative consequences and they feel compelled to consume, but they just feel like they can't stop. And to me, when we hear this sort of work in our qualitative research and on the scale, this really feels different than somebody who's maybe having that one extra cookie or an extra slice of pizza, but is really moving into that realm where there is impairment, distress, and a real threat to their life and their well-being. Next slide, please. So 2 recent meta-analyses have been published, both in adults and kids, based on over 200 empirical studies from around the globe. And based on these meta-analyses, the current estimated prevalence of food addiction is 31% in clinical samples of adults. These are adults coming in for weight loss concerns or binge eating or depression or anxiety. We see that in non-clinical samples, just community samples of adults, the estimated prevalence is about 14%. And that's really similar to things like we see with alcohol, which also has, an estimated prevalence rate of about 14% for alcohol use disorder. So although about 90% of people drink alcohol at some point in their lifetime, about 14% will meet that alcohol use disorder criteria. And we're seeing that really similar prevalence rate when it comes to this conceptualization of food addiction. One thing that's really unique, I think, about this idea of these highly processed foods as an addictive substance is the magnitude to which children are targeted and exposed in consuming them. Right now, the current estimates is that between 60 to 70% of the average American child's diet is highly processed food. And when based on these meta-analyses, we're seeing that about 19% of children with overweight meet this food addiction criteria, and 12% of just community children would meet that. And that's so striking when we think about addictions as something that typically children are more protected from, although with the potential debates around gaming and pornography and social media, our conceptualizations here might change. Next slide, please. And there's a little click if you want to click on an animation on the next one, it should pop up. Thank you. So this is just to talk a little bit about the association of food addiction and weight status. So what you can see on this bar here is, total food addiction prevalence, the likelihood of meeting that food addiction diagnosis or not. And again, when we look at samples of individuals with obesity, it does look like about 1 out of every 3 individuals are meeting. And I just like to highlight here that that means that obesity and this addictive phenotype are not synonymous with one another. It does seem to be a subtype of individuals with obesity, which makes sense because obesity is a multifactorial condition. It can be related to medications and genetics. But I also want to point out in those bars is that you see that there's not an insubstantial percentage of people who are normal weight, around 7%, who are also meeting for this food addiction criteria. If we compare that to something like our existent eating disorders in the DSM, we see that about 1% of individuals meet for binge eating disorder, and we're seeing that about 7% of individuals with normal weight are meeting for this food addiction cutoff. And so, I think we can't look at someone's body shape or size and assume we necessarily know whether they have an addictive relationship with these foods. And it's important to kind of really look at the behavioral phenotype to get closer to that. Next slide. And so I've been saying kind of food addiction on and off, which is what we started with when we started this work. And part of that was because there really wasn't science at that point to kind of guide us towards, is it all foods? In which, this really might then just be the act of eating in general, which I think would fit more with a behavioral addiction. Or is it something about the types of foods that people ingest that really mimic the effects of addictive drugs, in which case a substance addiction frame might be more specific and more effective here? And so Erica Lafata, who's a doctoral student of mine previously, who's now a faculty member at Drexel University, has really kind of dug into this question. And we've taken what we know about addictive drug psychopharmacology and considered that, drugs that provide an increased dose of an addictive agent and that particularly have a rapid rate of absorption into this system. So smoking a cigarette versus a slow release nicotine patch have a higher addictive potential. And so when we've looked at our food supply, it's been really clear that, especially since the 1980s, we've particularly increased the dose of rewarding ingredients like sugar and fat in our food supply. But we've also processed our food and changed their food matrices in a way that stripped out fiber and water and protein that has led the foods to be more easily consumed, digested, and absorbed in a way that processed foods really increase the rate of absorption of ingredients like sugar and fat into the system. And so our theory was that it wasn't all foods that were related to this addictive phenotype, but rather really highly processed foods that were triggering it. And so we did a study where we gave people the Yale Food Addiction Scale, which generally primes people to think about those highly rewarding, highly processed foods. We removed that prime, and instead we just asked people to rate the diagnostic criteria. And then we compared 35 nutritionally diverse foods and said, which one are you more likely to experience those sorts of behaviors with, and a forced choice task. Next slide, please. So what you see here are the foods that were at the top of the list of the sorts of foods that people reported experiencing more addictive responses to. And this is probably the least shocking slide I ever show in my research. It's chocolate and ice cream and French fries and pizza. I've never had anybody kind of be shocked by that. I think that kind of is intuitive. And these are all foods that do not exist in nature, that are processed foods that have unnaturally intensely high levels of refined carbohydrates plus added fats. And that's something that we just don't see in nature. Natural foods come either high in carbohydrate or fat. They don't come combined together, especially not at these levels and not at these absorption rates. Next slide, please. What foods were at the bottom of the list were naturally minimally processed occurring foods. Even those that are kind of naturally higher in sugar, like an apple or a banana, were not highly rated as consumed in an addictive way. And I think that's because these foods are intact. They don't have quite the same level. They don't have quite the same degree of absorption. They're not complemented and supplemented by fat as well. And so it really appears that these foods kind of differ. And this has been now replicated in a number of studies when we've looked at what foods might be most implicated in this addictive process. It's these highly processed, high refined carbohydrate, high fat foods. So it doesn't appear to be the active eating in general, but rather the intake specifically of those intensely rewarding foods. Next slide, please. And when we look at that to try and understand what impact might this high sugar, high fat, high processed food be having on the brain, and could it really resemble what we see with other addictive substances? What I'm showing here is microdialysis findings in animals that have been administered either ethanol or nicotine. And you can see that the rate of dopamine release and mesolimbic dopamine systems for those addictive agents is around 150 to 200% above baseline, depending on the dose and the neural region. Next slide, please. And if we look at that same model of microdialysis of dopamine release, and we look at that, whether we're probing sugar or fat, or actually highly processed foods like these Fonzies, which are kind of Italian Cheetos, we see that the magnitude of mesolimbic dopamine release for these foods is also in this 150 to 200% of mesolimbic dopaminergic release. And so when we look at these foods, they're engaging kind of very similar neural reward systems and at very similar magnitudes as the release that we see with known addictive agents like nicotine, ethanol, suggesting that they might really be mimicking these same effects. Next slide, please. And so to again give an example from a quote of kind of the specificity here, as this is a quote of someone's lived experience of, I do it all the time, but just one example is I went to the mall, which is 30 or 40 minutes away from my house, just to get a Cinnabon, and I got extra sauce on it. And I have other foods in the house. I might have my fruits and veggies in there, but I'm still going to go to the store and get the Reese's peanut butter cups and the Doritos and 2 or 3 pops. And this is somebody with severe food addiction and also very low food security. They don't have enough money to get food. And here, when they have fruits and veggies in their house, that's not doing it. They really want the specificity of those highly processed foods and are willing to go out of their way to get it. So to me, it talks to the specificity of that food. Next slide, please. And I'll finish up here. So just to kind of sum up, I'm going to go through these quickly. We see that this food addiction phenotype does co-occur with high-risk substance use disorders like alcohol, smoking, and vaping. Next slide. That activation of neural reward regions, especially to cues, is something that's implicated with higher food addiction symptoms. Next slide. That there's a little animation. That lower inhibitory control is also implicated in this food addiction profile, akin to other addictive disorders, such as increased urgency or a tendency to engage in delayed discounting. Next slide. And I'm going to have you go ahead and click one more, please. What we see is that food addiction also predicts a failure to respond to traditional treatments for weight loss, where individuals with food addiction are 43% more likely to drop out of weight loss treatments. Next slide. And click of animation. And 46% more likely that if they stay in, they gain weight rather than lose it. Next slide. And we're also seeing that they have a lower quality of life, even when accounting for body mass index across physical, psychological, social, and environmental domains. Next slide. As we talked about, many of the treatment approaches that have been discussed in the context of other addictions are particularly relevant in this context of food addiction, but the treatment is lacking, or the investigation is lacking, and this is really an important future direction. And next slide. And just to thank you, and if you click one more, this is my lab, my little fast food restaurant, and there's a site reference there where you can get access to the food addiction scale and other scales we have for free. Okay, thank you, everyone. I appreciate your time.
Thank you, actually, for the excellent presentation. And our final speaker is Dr. Deborah Sinclair. She's a research psychologist and counselor. She's also a member of the Recovery and Addiction Research Cluster at Ghent University's Department of Special Needs and Education. And she received her joint PhD in psychology and educational sciences from Ghent University, Belgium, and the University of Western Cape, South Africa. Her current research focuses on recovery-oriented interventions and substance and behavioral substitute addictions in recovery. Go ahead, Dr. Sinclair, take it away.
Thank you so much. Good day, everyone, and thank you for the opportunity to be part of this interesting and very timely webinar. So in the interest of time, I'm going to get right into it. What is a substitute addiction? A substitute addiction is said to be present when one abstains from an addictive behavior and subsequently replaces it with another or other addictive behaviors. The substitute may begin, resume, or increase in frequency and or intensity after addressing a targeted addictive behavior. For instance, what somebody might consider to be their primary addictive behavior through treatment, for instance. The substitute then serves at least one key function of the now terminated behavior. Motives for substituting addictions might include wanting to reduce harm or managing cravings, for instance. So how does this fit into the broader theme that we've been discussing so far? Well, the primary addiction might be a behavioral addiction, and the substitute or replacement behavior that somebody engages in might also be a behavioral addiction. So we can stay on this slide. Thank you, Vicky. So while substitute addictions have long been reported clinically, there's a paucity of research on the topic. And over the course of the next few minutes, I will briefly take you through a multiple method study, 5 sub-studies that we conducted over the last few years in order to start addressing this gap in knowledge. What's important here is that we considered the topic of substitution from the perspective of the literature, from the perspective of treatment service users, from the perspective of treatment providers, but also people who were in recovery support groups representing another pathway to coming into recovery. Next slide, please. Thank you. So the first sub-study we conducted was a scoping review of the literature on substitution. And in particular, our focus was substitutes that arose for people who previously had a substance use disorder. We opted to do a scoping review to chart the research arena because scoping reviews do not impose a quality criteria on the studies. And so this would really give us an overview of the available literature. What we found was that there were 63 studies that met our criteria, largely quantitative in nature, almost exclusively conducted in the US, and while you might say that, while that's a fairly large number of articles to be included, we found that substitute addictions was really the primary focus of these studies. Often it was a residual outcome of studies targeting something else. We also found that primarily these studies detailed replacing one substance with another. But given that behavioral addictions is fairly recently coming to the foreground, this could be a byproduct of the time period of the review, and that there was a lack of a consistent definition of what substitution entails. Lastly, we also found that there were a variety of terms used to refer to substitution, and that terms such as addiction transfer, for instance, specifically referred to bariatric surgery patients who gravitated towards other addictive behaviors post-surgery. Next slide, please. So I want to preface the slide by saying that what's considered licit or illicit is a matter of context. But in terms of what we found in these 63 studies was that alcohol was a licit replacement for primary substance in the samples that we reviewed, and that in terms of illicit substitutes, we saw cannabis coming to the fore and cocaine, for instance. In terms of behavioral substitutes, there was some evidence for gaming and pornography viewing as replacements for substance use. It was easy to conclude based on these studies then that substitutes often had their onset during early recovery, but this also emerged as a methodological weakness in that studies were mostly conducted with treatment-seeking samples and not with people who might have been in recovery for longer periods of time. I think importantly, what also came out of these studies is that substitution is not necessarily long-term. someone may replace their primary substance temporarily in response to contextual factors such as limited availability of a desired substance of choice. Next slide, please. So coming back to this issue of context, and my research, when I get into the empirical studies that I'll be describing in the next few minutes, my research was conducted in South Africa. And during the COVID-19 pandemic, South Africa had a particularly unique response. Amidst the lockdowns, there were also bans placed on alcohol and cigarettes for protracted periods of time, actually. And this gave rise to what you might say was a situation of forced abstinence. So this was sort of a natural experiment for exploring substitution and seeing what might be happening with people who might have been seeking out alcohol use or cigarettes during this period. So congruent with historical examples where we see changes in policy or changes in availability of certain substances, we saw that certain people complied and abstained from alcohol and cigarettes during this period. We also saw that some people sought out alternatives for their primary addiction. So for instance, some people took to brewing their own alcohol, sometimes with fatal consequences. And of course, we also saw some substitution during this period. And I have to say, all of this amidst continued illegal sale of cigarettes and alcohol, of course, and a thriving black market that might now take years to dismantle. So just because it was considered illegal didn't mean that people were no longer trading in it. Next slide, please. So during this period, I was in contact with one of my participants who was a former member, who was a member of Alcoholics Anonymous and has been in recovery from alcohol use for a period of 25 years. And what he relayed to me through our many conversations was that his long-term replacement for his alcohol use was pornography viewing. And that a couple of weeks before the hard lockdown that we experienced in March of that year, that he had stopped viewing pornography, but was facing various difficulties amidst the limited movement that was permitted during that time and the stress of that period. So essentially, he relapsed to pornography use. And when we really looked at the various factors that might have had a role in his relapse to his substitute behavior, his long-term substitute, we saw that there was an interplay of various environmental factors, individual level factors, and also factors pertaining to the addictive behavior. During that period, Alcoholics Anonymous meetings transitioned into an online space. And for him, that was problematic in that his anonymity might have been jeopardized. So he opted to stop attending recovery support meetings, having attended religiously for 25 years. So from an environmental standpoint, then one could say that he had reduced recovery support during that period. During that period, as we couldn't leave home, many people gravitated towards internet-based behaviors. And this was actually the way in which he accessed pornography. If you want more detail on this, I would refer you to the publication over there. But what we really saw with him is that there was a change in how he accessed pornography over time, and his medium for access ultimately was the internet, and this was sort of facilitated while being at home. From an individual standpoint, the stress that most people experienced during that period, and by his own account, overwhelming his coping skills, were factors that played into his relapse to his pornography use. And in his particular case, he had just started attending Sex and Love Addicts Anonymous meetings for his pornography viewing. So there were many aspects of his pornography viewing that remained unaddressed during that time. Then in terms of the addictive behavior, and Steve has a model on this, the PACE model, there are various factors which may play a role in why somebody might gravitate towards a certain behavior. In this particular case, he of course also had experience of pornography, knew what quote unquote payout he would get from viewing. And so that might also be why he gravitated towards that and not some other online based behavior. Next slide, please. So the third sub-study that we conducted was targeted at treatment service users, people who were attending 6 different treatment facilities, residential treatment facilities in South Africa. We were able to recruit a sample of 207 and retain 65% of them and followed them up for a period of several months after their treatment. What we found was that 36% substituted for the primary substance they indicated at treatment entry. 23% reported relapse into their primary substance, and 40% reported maintaining abstinence. Because this is such an under-researched area, we asked people in an open-ended way, why do you think you gravitated towards some of these substitutes? And what came to the fore quite strongly was anticipated appetitive effects. So, for example, somebody might instrumentally make use of a substance or a behavior for an intended effect, such as managing cravings, for example, or for more energy. Another one I'll highlight here is time spending. Oftentimes, when substance use occupies so much of your time, you now have all of this free time, and boredom sometimes comes into play during recovery. So people gravitated towards a range of other behaviors to while away the time. We also administered the brief assessment of recovery capital and had almost a textbook finding here, in the sense that those who had lower levels of recovery capital tended to be those who relapsed. Those who had medium scores tended to be those who substituted, and those with higher scores tended to be those who still reported abstinence at treatment follow-up. Next slide, please. So I'm not going to dwell too long on this, but these were the key substitutes that were reported. You'll notice that love emerged as the leading substitute. I'm careful here to call it a substitute behavior, and I'll embellish this point a bit more later on, but I think that we risk trivializing the term addiction if we apply the word substitute addiction too loosely, when we actually might just be talking about changes we expect to see after treatment, or behaviors that don't quite rise to the level of an addictive behavior. But we were just intrigued to find that love was reported to be the primary replacement. And I think, again, this comes back to Steve's presentation, where he spoke about that need for relatedness and belonging that people might experience. Notice also that relatively few substances came to the fore. Okay, in the interest of time, I'm going to move along. We can skip past study 4. Yeah. So, yeah. Again, I invite you to read the related publication, but I'm just going to hone in on our last sub-study, which is with members of Narcotics Anonymous. So this was important for a few reasons. People enter recovery through various pathways. And in doing this study, the first of its kind, we were able to explore substitution from the perspective of people who might not necessarily have attained recovery through treatment, though some of the sample did. I just want to refer you there, again, in the interest of time, to the quote from one of the participants. This participant reported excessive work and also a sex addiction, according to him. And if we just look at the quote there in the middle, he speaks about how he knows it's going to take him back to his primary addiction, which was crystal methamphetamine use. So here we really see that there's an interplay between behaviors. These behaviors don't happen in isolation. A behavioral addiction might become problematic for someone, but it could also play a role in the recovery process from the primary substance. Okay, so in conclusion then, I've just got my last 2 slides. There are a couple of clinical implications that emanate from this work. And the first, of course, awareness is very important, is to recognize the potential risk for substitute addictions to occur. One of the sub-studies I didn't get to discuss was with treatment service providers. And what emerged there was that people don't always screen for the presence of multiple addictions when people come into treatment. That is so critical because there are dynamics and interactions between those various substances and behaviors. So what's very important is vigilance and building recovery capital collaboratively. You can just go to my next slide. So as I mentioned previously, I think it's very important that if we use the word addiction, we need to make sure that there are key addiction characteristics that are present. But also that just because a substitute is present doesn't necessarily mean that relapse is imminent or that it will rise to the level of an addiction, because it can be temporary. So importantly, and I want to conclude with this point, families, people in recovery themselves, and practitioners need to consider the relative harm of the substitute and do a case-by-case risk analysis. Thank you so much.
Thank you, Deborah. That was fascinating. And at this point, I ask all of the panelists to please turn on their cameras, and we will do a Q&A. So great series of talks. This one comes in, I'm going to twist it a little bit, from Dr. Rob. So he says, he talks about this idea of highly processed, and I think he was cued by Ashley's work, but I'm going to kind of broaden it. So, highly processed, highly engineered. We can think about the pornography industry. We can think about the gaming industry. And of course, foods, technology advances, and it only allows more rewarding stimuli to be produced. I'd like to have each of the speakers maybe give a little tidbit on what they think. So I'm just going to go in order and call you off, and I'll start with Dr. Kim and order on my screen. So go ahead, Andrew. What do you think about this topic?
Yeah, I think at least in terms of the gambling, in terms of technology, what I think it boils down to in terms of the risk or addictive potential is sort of the rate of reinforcement. Dr. Gearhart talked about how much certain processed foods can increase dopamine. In terms of the gambling and gaming field, it's, I would say, the rate of reinforcement. So for example, slot machines, every 3-4 seconds, you get a hit of dopamine in a sense, right? Gaming as well, there's a lot of different avenues to get the reward-related symptoms. And there are also other cues that technology can embed. So all these sounds and lights that kind of sometimes can trick your brain into winning. And so in terms of the technology and how that advances gambling gaming, rate of reinforcement and realism. So one thing that I am curious about academically, but also maybe a little worried about, is once VR headsets and augmented reality become much more, the technology becomes up there and you can really immerse yourself.
Sure.
That's going to then impact our reward systems.
Fascinating. Yeah. And that applies maybe to love too, not just sex when we think about romance. So Dr. Sussman?
Yeah. Well, it speaks to, I don't know, to, cite Japanese breakfast, it's a rush. You get a, very fast kind of spiking in that impacts neurotransmission. It does something for the individual. It manipulates the appetitive motivation systems, or we talk about kind of the terminal being the mesolimbic mesodopaminergic system, but it involves a lot of neurotransmitters, and it does something for the person, and then it does something to the person to kind of cite kind of 12-step, perspective. And yeah, and this operates for a variety of different addictions, so heck, welcome.
Yeah, well, good summary and commonality. Dr. Gearhart.
Yeah, I think that's one of the things that strikes me is that as technology across all these domains improves, the evolutionary mismatch between the sort of reward profile our brain evolved to manage and what it's being exposed to all the time in our society across multiple domains is becoming imbalanced. And one thing that stuck out to me during Dr. Sinclair's talk is that idea of kind of alternative reinforcers. And if we think of things like connection or physical activity or love and those kind of healthy, I think of them as more low and slow and sustainable and nourishing reinforcers. In our modern world, those are becoming harder to come by and we're all stressed and kind of deprived. And then I think we're turning to these highly available, potent, but potentially addictive reinforcers because they're more accessible.
Love that. Nourishing, not just for food. Dr. Sinclair, please comment.
I think the only thing I'll add in terms of technology and its contribution is that the internet facilitates access to a number of potentially addictive behaviors, gambling, sex-related, behaviors. So we also have to distinguish between, and I think Mark Griffiths says this, addictions to the internet and addictions on the internet, but certainly the internet plays an important role in facilitating access. Yeah.
That's a great point, right? Yeah, because the internet is part of life. And Dr. Reed, please comment.
So, it's interesting. A lot of the things that promote products, if you will, that those products can be addictive, they're interested in profits. And so how do they determine that? Well, the same regression models that we use to understand addiction, they're using to understand profits. And the very neuroscience that we use to understand addictions, they are using to get people addicted. Although they won't call it that, they'll simply say, we're trying to maximize and optimize sales, profits, and what the collateral damage is as a result of that. They will say, well, the fact that only 3% of people are getting addicted to gambling says that, our product largely isn't addictive for the vast majority of people. And so there are all of these invisible forces at play. You look at some of the research on fat, salt, and sugar that has been done. That's places like, and we won't name places like Cheesecake Factory and the like, that for a long time use that same. They had rat labs and so forth, understanding what are the maximum things. So I think we're always going to be faced with this challenge of helping people understand these things, but also not fall victim to the various invisible forces that are likely to hijack their hypothalamus and override their choice.
Yeah, and that's a great point. And, obviously this applies to substance addictions too. I study e-cigarettes, and technology has been critical to making those products, which the industry might use the term more appealing, and we might use the term more addictive. So another kind of cross-cutting question, and sorry to, there was a student who asked a question, and it would be a great question, but it might take us 5 hours to answer. But we encourage you to continue in the field of addictive science, and feel free to follow up if you want to get more in the weeds about career advice related stuff. So let me talk about, or let me raise the question. I'm going to start with Dr. Sinclair. So a lot of you reviewed that there was comorbidity, right, or co-occurrence of multiple addictive disorders. Can you talk about, and we have some clinicians here too, is substitute addictions, and almost thinking about like harm reduction, right? So to what extent should we be concerned about substitute addictions? To what extent can we harness them? So Dr. Sinclair, can you please begin?
Thank you for this question. I don't think there's a, I'm smiling at Steve because we are interrogating this topic at this very moment with a commentary. I don't think there's necessarily a one-size-fits-all answer here, but just to say that the perspective really is that if someone has had the lived experience of an addictive behavior, chances are they should be able to recognize when the replacement behavior is tending to go in the same direction in terms of the impact on relationships, the impact on role fulfillment, and the effect it's having on their life. So I think personal monitoring remains important over the course of recovery. But again, the substitute could be time limited. Yeah. It could aid them in the recovery process. It's not necessarily bad to be trying something different. Steve, maybe you want to add something though.
Go ahead, Steve.
Well, yeah, that was suggested by Tom Harvath in his work in smart recovery. But we are working on a commentary, should be submitted very soon. I did a revision while standing in line at California Adventure and Disneyland. So I encourage everyone to feed your Disney buzz by getting out there and standing in line and doing work. But,
that's how you write 600 papers. So hey, so Dr. Reed, I'm interested in getting your take in terms of treating patients with compulsive sexual problems. So what do you think about this substitute and harm reduction issue?
So I think if we take a look at the underlying issues that are giving rise to these addictive behaviors and the commonalities that they share across these addictions, I think we need to be able to do some psychoeducation with our patients to say, listen, we're addressing shame, we're addressing loneliness, your depression, your anxiety, your ADHD. And now we've resolved and attenuated some of this dysregulated sexual behavior. But be aware that you can very subtly get lured into other kinds of addictive behavior. So I think just being aware of the fact that there could be crossover addiction. But I think if we're really, as clinicians, adequately addressing these underlying issues, there shouldn't be a need to escape through food or problem gambling and the like. That being said, I would just revert back to my other comment previously. all of these invisible forces at play. When you walk into a casino, or you walk into a, just think about how moral licensing is used in food advertising and things like that. There are so many invisible forces that are captivating or capitalizing on the neuroscience that we know and understand to hijack people's decision making and judgment, that we always need to be on guard with, and help our patients be aware of these nuances so that they don't fall prey to other addictive behaviors.
Well said. Well, I think we could go on and talking for hours, and next time we'll book a 2-hour slot when you have 5 great scientists. So if you do have additional questions, we encourage you to email them to Vicki Williams, and then we can forward them to the panelists for their responses. So with that, let me go ahead and wrap up, and let's thank our wonderful international group of speakers who really did an awesome job. I think this probably would be one of the best panels you could ever see on the topic of behavioral addictions. And please tune into any future webinar or in-person presentation that we offer here at the USC Institute for Addiction Science. Have a great weekend, everyone. Thank you.